Good morning all. My name is Dr. Muhammad Yahaya. I am Associate Professor and Consultant Clinical Microbiologist. You are welcome to a presentation organized by the Medical and Dental Consultant Association of Nigeria, Sokoto State Chapter, and Pfizer Incorporated. I will be taking you on healthcare associated infections as a driver to antimicrobial resistance. I will be taking the presentation. I will start with background. We define terms of healthcare associated infection, the types, the different pathogens of antimicrobial resistance. Then we look at the mode of transmission of healthcare associated infections. Then we look at the global and local burden. And then we finalize with the UDUTHS experience on dealing with healthcare associated infections and AMR challenges. History of antimicrobial resistance actually predates the use of antibiotics for treatment. And in fact, antimicrobial resistance implies the resistance to antibacterial, antiviral, antiparasitic, and antifungal resistance. But for emphasis, this presentation will rely more on antibacterial resistance. We should understand that with the exception of 2 drugs, no new antibiotic has been developed since 1980s. That's almost 30 years. And the available antibiotics pathogens are developing resistance to it daily. It means that we will therefore we're having a dry pipeline. We end up exhausting the antibiotics we have without a global concerted action, similar to what was done for HIV/AIDS and COVID. We will die by the year 2050 without a global concerted action. It was because of this that there was a resolution as far back as 1998 by the World Health Assembly on strategies, global strategies for the containment of antimicrobial resistance. It was even the topic of discussion and the main theme of discussion at the 68th World Health Assembly in 2015, where the Global Action Plan on Antimicrobial Resistance was established. It was also the subject of the United Nations Agenda meeting for this year, where there was a high-level interactive dialogue on antimicrobial resistance. Now, coming back to healthcare-associated infections, they have emerged as global challenge, not only affecting patient safety, but also as a driver to antimicrobial resistance. They are now a major cause of mortality and morbidity with the attendant economic consequences. The emergence and spread of antimicrobial resistance now constitute a threat to effective control and treatment of infections worldwide. Healthcare-associated infections are usually caused by multi-drug resistant organisms, and because we lack or we don't deploy efficient infection prevention control mechanism, this further lead to widespread transmission. Thereby, healthcare-associated infections serves as drivers to AMR and also vice versa. Now, I want us to recall or to look at these 2 live situations of healthcare-associated infections. Now, the first scenario is that a baby was born prematurely, and the outcome was that she was progressing in the neonatal intensive care unit until she developed a bloodstream infection that was related to her umbilical cord care. This is a familiar situation in most of our special care baby units. The second scenario is a father that had an open surgery. The surgery went well, he was admitted, but he later on died due to a multi-drug resistant pathogen from the wound infection that developed post-surgery, the multi-drug resistant Staphylococcus aureus. The third scenario is a sister that contracts Clostridium difficile after giving birth. She has lived with this unbearable condition through her 6 months of relapse. The fourth scenario is a mother that is being treated for cancer, but she now has to fight 2 diseases because of infection with hepatitis B due to unsafe injection. Now, what is the definition of healthcare associated infections? These are infections that patients acquire during the course of receiving treatment and that was not incubating at the time of admission within a healthcare setting. Previously, this has been referred to as nosocomial infection, but the more appropriate term is to use healthcare associated infection because there are other facilities that provide healthcare apart from the nosocomial or hospital settings that will be left out if we use the definition of nosocomial or hospital acquired. So it's a more encompassing term to use healthcare associated infections. Now let's look at the types of healthcare associated infections that exist. We have the urinary tract infections acquired in the hospital, which can be catheter related or not. We can have the bloodstream associated infections. We can have the central line associated bloodstream infection. We can have the surgical site infections, or we can have ventilator associated events, pneumonia and other ventilator events. We can have others, infection of the bones, joints, soft tissue, and cardiovascular systems. Now, the AMR pathogens that have been implicated in healthcare associated infection, for the gram-positive bacteria, we have the penicillinase producing bacteria, we have the methicillin resistant Staphylococcus aureus, we have the vancomycin resistant Staphylococcus aureus, and also the vancomycin resistant enterococci. For the gram-negative bacteria, we also have bacteria producing penicillinase, beta-lactamase producing bacteria, extended spectrum beta-lactamase producing Escherichia coli, Klebsiella, and also Proteus. We also have carbapenem resistant enterobacteria and also Clostridium resistant among several gram-negative pathogens. Now, the drivers to this AMR, number one driver is the misuse and overuse to antimicrobials. Lack of access to clean water, sanitation, and hygiene for both animals and humans constitutes as a challenges to effective implementation of the infection prevention and control measures. We also have the poor policy and implementation of infection and disease control and prevention in healthcare facilities and farms. We have poor access to quality and affordable medicine, and then we have structural and functional weakness in our health system, and this has been a driver to medical tourism with the consequences of importing other pathogens from most of these countries back to our facilities. We also have undetected healthcare associated infections as a driver to antimicrobial resistance. What is the mode of transmission of healthcare associated infection? The mode of transmission can be by direct contact or through indirect contact. In direct contact, we can have contact with patient's body through the hands of the staff or through the hands of the patient, and this is why we restrict entry at certain points to our facilities. And we can have some common pathogens that have been implicated, as earlier mentioned, like the methicillin resistant Staphylococcus aureus, the ESBL, the vancomycin resistant enterococci, and Clostridium difficile. Now, indirectly, we can have others like medical devices, door handles, tables, computer keyboard, and even doctor's necktie. I remember a study that we did in one institution where we found out high burden of drug-resistant pathogen among doctor's necktie. We can have also through hospital foods. It can be through airborne, like the cough, sneeze, even electrical appliances, and sometimes inadvertently to lose the parenteral route. So now we look at the epidemiology of healthcare associated infections and AMR. 1 out of 20 patients will eventually develop healthcare associated infection in developed countries following admission, while 1 out of 10 will develop healthcare associated infection in any developing country following admission. Now it has been projected that 40 to 60% of these patients may die as a result of this infection that they acquire without appropriate treatment. And healthcare associated infections rank among the top 10 leading causes of death in the United States, accounting for about 1.7 million affected individuals and about 99,000 deaths in 2002, and this resulted in an excess of $33 billion as economic cost. In England, they had more than 100,000 cases, and they are estimated to cost about £1 billion directly and over 5,000 deaths annually. Now, in Africa, we had a full prevalence of healthcare associated infection, which was estimated by a study by Eric et al. To be 15.5 per 100 patients, with a 95% confidence interval of 12.6 to 8.9. Surgical site infection was said to be the leading cause in Africa, and they were mainly caused by gram-negative organisms, which are multi-drug resistance and hence driving antimicrobial resistance. Multi-drug resistant organisms account for 25% of healthcare associated infections globally. It is also estimated that at present, antibiotic resistance lead to the death of about 700,000 people worldwide, and this figure has been projected to increase to 10 million by 2050 without a global concerted action, similar to what was done for HIV/AIDS and also presently COVID. This is showing a prevalence of healthcare associated infection. We can look at it in the developing countries concept, 4.5% in the United States. This was a 15-year prevalence. Norway 5.1, and also in Switzerland they have 10.1. Korea they have 3.7. Now, in our own part of the world, we had Malaysia with 13.9, Tunisia 17.9, Morocco 17.8. We can see that one thing that is striking about these two figures is that the range in developing countries, they have almost twice as high as in the developed countries, the average prevalence, and this should be a cause of concern to us. Now, coming down to Nigeria, multi-drug resistant tuberculosis prevalence is currently around 3.1 to 10.1% among new and retreatment cases respectively, and we should recall that Nigeria is among the countries that are in the first 27 with the high burden of tuberculosis. A situational analysis by the Nigeria Center for Disease Control in 2017 published a survey on Salmonella bacteria among children. They reviewed a survey of Salmonella bacteremia among children in central and northwestern Nigeria, and they indicated that there was 20.7 to 23.6% of Salmonella bacteremia cases that were due to non-typhoidal Salmonella, and these cases had a high proportion of resistance to ampicillin. The same study also showed a resistance of Staphylococcus aureus to ampicillin ranging from 0 to 95.6%, with least resistance in Oyo State, northwestern Nigeria, and the greatest resistance in Cross River State. Surgical site infections have been seen after cesarean sections or orthopedic maneuvers, and organisms mostly isolated included Staphylococcus aureus, Pseudomonas, Klebsiella, Proteus, Strobacter, and Escherichia coli. Healthcare associated infections as drivers to antimicrobial resistance. Based on what we have seen so far, we can see that there is a causal relationship between antimicrobial resistance and healthcare associated infections, and if left untreated, they will further accentuate the problem. The MDR strains of Acinetobacter baumannii have been isolated with increasing frequency from healthcare associated infected wounds, and this was reported by Albazi in 2020. In 2009, a report from the European Center for Disease Control showed that MDR, MRSA, methicillin resistant Staphylococcus aureus, was responsible for almost 50% gram-positive isolate of blood culture from patients with bloodstream infection, while for the gram-negatives, Escherichia extended spectrum beta-lactamase Klebsiella species accounted to almost greater than 50% gram-negative isolate from 7 European countries. Now, this is what I call the Danger of Triad, and this is a disaster to patient safety. It's a triad consisting of antimicrobial resistant pathogens, undetected healthcare associated infections, and a poor infection prevention and control practices. When these triads exist, we have a dangerous setting, and the only way we can approach it is by working together in a One Health approach, because we can have causes, antimicrobial pathogens from plant or environmental source that constitute a nuisance or a challenge to a patient that has been admitted in the hospital. Now, let's review. We are in the COVID pandemic era now. We are not yet out. Before the arrival of coronavirus disease, most of the professionals were preoccupied with antimicrobial resistance as an existential threat to global human health. But there is a fear that COVID-19 has reversed the gain made in most of the public health intervention measures. However, one good side about COVID-19 is that it has brought to the fore the necessity and the need for us to institute and improve on our infection prevention control practices. This may serve as a plus in addressing healthcare associated infection. COVID-19 has also shown us the disparities that exist in healthcare provision in terms of infrastructure, in terms of functionality and the rest. And it has also shown us that none of us is safe until all of us are safe. Now, this same adage applies to AMR. While AMR is going on silently, the realities might be more visible in the near time, and COVID might exacerbate these conditions. We need to advocate control strategies or responses for us to reverse this trend. One of these control strategies is we need to have global and local advocacy and political engagement. There is nothing that we could do without engaging our political leadership, and this starts from choosing the right leadership and also engaging them and bringing to them the problem at hand so that they are aware of the dangers we face. We also need to enhance awareness. We can see that even the medical curriculum as it is now does not capture issue of healthcare associated infection or antimicrobial resistance. If we check the NUC guideline or the MDCIN Red Book, we will not have anything that talks about that. The only way where doctors get information is by presentation or seminars, webinars of this sort. We need to also be coordinated, and we need to sort for partnership, regional, state level, regional, national, and also multi-sectoral with the private sectors and other companies. We need to have policies and guidelines for antimicrobial stewardship so that we can guide the use of antibiotics. We need to strengthen infection prevention and control. We also need to have water, sanitation, and hygiene being established in all our facilities and communities. We need to optimize the use of antimicrobial medicines in the context of One Health approach. We should not allow the indiscriminate use of antibiotics such as it is obtained now in our farms, in our animals, in chemists. Almost anywhere you can buy antibiotics, and this is a dangerous threat because this is leading to selective pressure that may cause resistance to the pathogen. We also need to improve the quality and coverage of antimicrobial resistance surveillance, and we need to strengthen our healthcare systems. What is the state of our primary health centers? Can we afford to take our children there? What is the state of our general hospitals and also teaching hospitals? We need to ensure that they are properly manned, equipped, and the services rendered are optimal. We also need to have a robust data on healthcare associated infection. We need to focus attention to policy makers so that they can recognize this effect, this threat we are having, and we need to have incentives or disincentives to promote system changes by way of reward and punishment so that we can have sustainable healthcare associated infection prevention. A One Health framework should be extended to local and regional centers across the nation to improve on this change. We should revise the 5 action points proposed by WHO to combat antimicrobial resistance in 2015. The first is improvement in diagnosis. We should have the capacity to do culture for most of the pathogens that are culturable, and we should have a reliable way of reporting sensitivity pattern. How confident are we about the susceptibility testing we generate from our laboratories or even the culture result? We should also have appropriate policy for drug use, and we should regulate the use of drugs in animals. We need to visit poultries and see how people are administering drugs, antibiotics indiscriminately to poultries that we end up consuming, and we need to strengthen our infection and control practices. One last area that is very important is we need to invest more in research and development. I was reviewing the expenditure of a state government for COVID, and I saw no allocation for research and development. Most of the allocations were going to infrastructure, payment of stipends, purchase of vehicle, but there was no single naira that was allocated for research and development. So these are the 7 strategies that if we employ, they will be able to help us to reduce the burden of healthcare associated infection. This is hand hygiene is number 1, then environmental hygiene, screening and cohorting of patients. I have seen in most of the hospitals I visited, this is being pursued now with vigor. We also need to initiate and strengthen the existing surveillance system we have for the healthcare associated infection. We need to establish antibiotic stewardship. We should not allow indiscriminate prescribing of antibiotics. We need to institute an antibiotic stewardship. At least let's start with our tertiary and general hospital, and then we need to follow standard guidelines. We should have a safety culture. Now, in the next few slides, I will review our challenges, our experiences on dealing with healthcare associated infection and AMR in UDUTHS. We had performed operational research. We were part of the team for the NCDC, Nigeria Center for Disease Control, situational analysis in 2017. We also participated in an antimicrobial stewardship assessment checklist as approved by WHO. This was a paper published by Dr. Irebu, and several hospitals participated. We have an IPC committee, and we have not yet commenced our antimicrobial stewardship, but we are in the final phase of the pre-implementation plan. Now let's review them briefly. These were some of the operational researches we conducted, and I think one of the most important outcomes from this is the publication we had with Kauja et al. In 2021, where we found out that the greater percentage of our healthcare associated infections from Sokoto were actually surgical site infections, and the methicillin-resistant Staphylococcus aureus was one of the pathogens with higher proportion of being isolated. Another outcome from these researches that we conducted was that when for gram-negatives, we also found out that Pseudomonas aeruginosa was the common isolate from our facility. Another outcome was a study we did with Tanko in 2021, where we isolated Escherichia coli, and we found out that almost 50% of them were genetically related, meaning that they were circulating from the same patient in the hospital within a cohort. Was it the healthcare workers that were circulating this pathogen? Was it through our devices? We really don't know. But this just underscores the importance of infection prevention and control practices. Another thing that we participated in was to provide the data for the situational analysis, which led to the production of 2 guiding documents that underpin Nigeria's response to antimicrobial resistance. The first document was Antimicrobial Resistance in Nigeria, Situational Analysis and Recommendation. These documents are available online. And then the second one is the National Action Plan for Antimicrobial Resistance 2017 to 2022. It's due for review next year. We participated, as I mentioned, in this paper that was published by the African Journal of Clinical and Experimental Microbiology under the editorship of Professor S.S. Taiwo. We participated as one of the collaborating centers to provide data, and the finding was that we selected 20 hospitals, teaching hospitals, randomly to assess the existence of antimicrobial stewardship and also their preparedness. But only 6 out of these 20 hospitals have a committee on AMS, while only 2 had any evidence of leadership commitment to antimicrobial stewardship. And despite the fact that all the hospitals have laboratories and they have facilities to support culture and sensitivity. Some of the challenges they mentioned in the implementation of AMS at that point were the seeming lack of commitment by management, and also the lack of knowledge and adequate communication among prescribers and also stakeholders. We have an infection prevention and control team. Is functional. We have a chairman, a clinical microbiologist, Dr. Zainu. They meet regularly, and we have action trackers, and they implement and review them as at when necessary. And we also have our infection prevention and control guideline document approved, and it's been enforced. We have not done so well on the antimicrobial stewardship. We had created awareness, we have gotten commitment of our leadership, but we are yet to implement, which we hope to do in the coming few months. And this is a major setback on our part, which we hope to correct. Before I round up this presentation, I want to give us an assignment to each and every one of us. When we go back, let's review the following in our facilities. What is the compliance to hand hygiene for healthcare workers in our hospital? Do we follow the 5 moments of hand hygiene before touching a patient, after touching a patient, after touching patient surrounding? Do we actually do it? Let's just observe and see. Do we comply to appropriate timing of antimicrobials for surgical prophylaxis, or we just administer them as we want? Do we have a policy or guideline for infection prevention and control? Is it written? Is it available? Do staff comply to it? Do we even have a team or a committee for infection prevention and control in our hospital? If we do, when last did they meet? Do we have the existence of antimicrobial stewardship? What is the policy on the use of urinary catheter in our facility? I have seen a patient that was on urinary catheter for almost 21 days. There is no how that he will not come down with urinary tract infection. Have we implemented problem measures as regards to this component of healthcare associated infections in our facility? Surgical site infection, urinary tract infection, and bloodstream. This is a working assignment for us to do and assess ourselves. How ready are we? What of if we are admitted next? What will happen? In conclusion, I wish to state that up to 70% of healthcare associated infections are preventable, and by preventing them, we will end up preventing preventing or reducing the antimicrobial resistance. We must have a deliberate policy to reduce the burden of healthcare associated infections and antimicrobial resistance in all of our facilities. If we don't act now, we are setting the stage for the post-antibiotic era, and that will be the end of medical practice as we know it. We will go back to the stone age of medical practice. Infection prevention and control is the only answer. Let's act now. Thank you very much for listening, and this is the end of my webinar. I will step back and allow the presentation to the moderator to continue. Thank you. In conclusion, we have seen the burden of healthcare associated infection and how they serve as drivers to antimicrobial resistance. Now, we should note that up to 70% of healthcare associated infections are preventable, and invariably it means that the antimicrobial resistance can be prevented. We must have a deliberate policy to reduce healthcare associated infection and AMR in all of our facilities. If we don't act now, we are just setting the stage for the post-antibiotic era, and that will be the end of medical practice as we know it. We will go back to the era of stone age in medical practice. Infection prevention and control is the only answer. Let us act now. Thank you very much for listening, and this is the end of my presentation.